Hi, good afternoon, all the students of 152 batch. Dr. Rajesh Patil here. Today we have practical class as you all are aware of. So as a part of online practical class by RGHS. So today's topics are as follows. They are being displayed there on the canvas on the screen there. So we will be dealing today gross specimens 3 and microscopy 5 slides. Gross specimens number 1 squamous cell carcinoma, number 2 malignant melanoma, number 3 adenocarcinoma of the cecum. These are three gross specimens that we'll be dealing with. And then the microscopy slides include squamous papilloma, follicular adenoma of the thyroid gland, squamous cell carcinoma again, basal cell carcinoma, and slide melanoma. Okay, so first we'll be dealing with the gross specimens description. The first one, that is the squamous cell carcinoma. So coming to this particular first picture there, showing you this particular gross specimen of squamous cell carcinoma. This specimen consists of the growth. You are able to see the growth there on the heel, arising from the heel. It's a circular lesion measuring 3 centimeter in diameter. So you can see there particular on the foot. So it is on the leg. There is a cauliflower like growth. This is around cauliflower like growth. Actually this is not 3 centimeter. It's around 8 centimeter into 3. Yeah. So 3 into 8 centimeters you can take it as. Okay. So growth arising from the heel extending to the leg and the sole. So origin is at the particular heel. And there are areas of ulceration and hemorrhage. Okay. So these squamous cell carcinomas, could be again, microscopically well differentiated, moderately differentiated, poorly differentiated and all. Usually they occur on the sun exposed areas or in the old burn scars, or when you take in the oral cavity, it could be due to the tobacco chewing habits, betel nut. So all these etiological factors. So on the sun exposed area here on the heel, that is extending into that particular leg. Okay, so around 3 into 8 centimeters the size. So this is a gross specimen of the squamous cell carcinoma foot. So moving on to the next one, that is malignant melanoma foot. So malignant melanoma, as you all know, it's a malignancy of the melanocytes. Okay, so origin of this particular lesion is from the melanocytes. So here gross specimen, you can visualize this. Again there is growth arising from the heel. Again here upper area, you can see that's black discolorated nodule, big nodule there. So this is again a size of around 4 centimeters by 3 centimeters in diameter, black in color, margins infiltrating into the neighboring tissues. You can see that particular margins here infiltrating into the particular tissue. The other part is the foot one, the upper part is the heel one here. So that is how usually melanomas, they can arise from anywhere on the body of the body where there is skin, wherever there is skin, sun exposed areas. So blackish discoloration is a clear cut clue that tilts our diagnosis into the melanomas. Okay, so usually you see these melanomas in a very fair colored people. So one of the greatest disadvantage that fair handsome people can have is that they are very sensible or sensitive to sun exposed areas wherein a melanoma can be formed. So these fair people should be aware of this. And apart from the skin surface over the body, the other lesions of melanomas, as you all know, are in the oral cavity, genital mucosal surfaces, esophagus, meninges, eyes, or upper part of your chest, back, legs, all these areas you can see this. So this was about the malignant melanomas. All the subtypes and all that will be dealing in the microscopy of this particular thing. So basically this is a malignant lesion of the melanocytes, commonly seen on the surface skin of our body. Okay. So moving on to the third specimen, adenocarcinoma of the cecum. So this is malignant lesion, the glandular malignancy of the cecum. Okay. So what you see here, you can see the inner mucosal rugosity, the enfoldings of this mucosa, and then at the center you can see a mass. That is nothing but the adenocarcinomatous mass there. So this is measuring around 6 into 2.5 inches. Remember inches, the measurement here scale is inches. Actually we should have a measuring scale besides this particular gross specimen so that we get a clear cut idea about the length. So that scale is missing here. So this nodule at the center is a polypoidal mass. Okay. So whole of the specimen of the cecum is measuring around 6 into 2.5 inches, whereas the nodule is measurement is in centimeters, that is 6 into 5 centimeters, the nodule, the central nodule, which is protruding and obstructing the lumen. Okay. So on cut section there is nodularity with areas of necrosis. And one more thing that you should be aware of here is the proximal and the distal resected portion. You should be aware of these are free from the lesion, free from the mass. There is no any mass extension being visualized here on the gross specimen. That's very important. Whenever there is a loop or a segment of colon is being removed, always check for the resected margins. The free resected margins is a good sign for the patient and for the treating doctor. So this mass, the malignant mass, is limited at the center of this particular segment of cecum. The important differentiation that you have to be aware of here is how you differentiate this particular lesion from a tuberculoma or the tubercle mass. So in tuberculosis of the cecum, the ileocecal junction, that's the commonest site for tuberculosis even. So how to differentiate this adenocarcinoma mass from a tubercular mass? The one and important differentiating point is ulceration, commonly seen in cases of adenocarcinoma mass. And the other important one is the fibrotic component that is present in tuberculosis. There will be extensive fibrous bands that are grossly visible too in cases of tubercular cecum. Okay, that is important differential diagnosis when it comes. So these are the three gross specimens that we studied here today. So you have to be aware of all these three gross specimens. Now moving on to the microscopic pictures. So first and the foremost microscopic slide that we are dealing with today is squamous papilloma. Okay. So these are nothing but this is a benign lesion. So these are nothing but the benign proliferation of stratified squamous epithelium. Benign proliferation of stratified squamous epithelium that results in papillary structures or verrucous exophytic masses. Okay. So in this microscopic picture you can see stratification, hyperkeratosis, even parakeratosis. What is parakeratosis? Retainment of the nuclei in the keratin layer when the keratin is being formed there. And then there is acanthosis of this layer, the squamous layer. Okay. So there could be again arborizing fibrovascular cores in these particular papillary structures. So these are again lined by keratinizing or non-keratinizing squamous epithelium. There could be stromal invasion or may not be there. Okay. So there is usually no necrosis, no mitosis. So there are finger-like processes of these papillary structures or the papillomatosis. Okay. So there are deep clefts. When there are more papillomas, it is called as papillomatosis basically. So microscopically there are finger-like papillary enfoldings of this particular surface epithelium. Okay. So there could be deep clefts So basically you should remember stratification of the epithelium, hyperkeratosis, parakeratosis, acanthosis. So these are the basic findings. So there could be again the arborizing fibrovascular cores could be lined by the keratinizing or non-keratinizing epithelium. So this is a picture that you have to draw the diagram in your record books. Okay. So moving on to the next slide. That is follicular adenoma of thyroid. Now what is this? This is basically a benign tumor of thyroid gland. So what you see basically here, well differentiated follicles. There are follicles, lined by cuboidal flattened follicular epithelium. At the center you can see colloid filled follicles situated in the stroma of this particular thyroid gland. See, basically it resembles a normal gland. Now how do you differentiate follicular adenoma from a normal thyroid gland? The only one important thing that you can that you notice is there should be a capsule in case of follicular adenoma, which is not present in a normal thyroid gland. So these follicular adenoma, wherever they form inside the stroma of an thyroid gland, this adenomatous component is clearly well demarcated from the surrounding thyroid normal tissue by a distinct capsule that you should be very much aware of. And then why is another importance of this particular capsule? You have to always check the capsule. Of course, in this microscopic picture there is no capsule here. This is higher power magnification. So when you go to lower power magnification, you can usually scan and focus on the capsule that surrounds the adenomatous components in a case of follicular adenoma. And you have to focus on this capsule also because to differentiate between follicular adenoma of thyroid from follicular carcinoma of thyroid. Why? In case of follicular carcinoma of thyroid, there could be infiltration of the neoplastic cells. When there is no infiltration of neoplastic cells in the capsule of a follicular adenoma or a follicular lesion, then it is adenomatous lesion. Okay, so these are the basic findings that you can see in a follicular adenoma. The important one is it is encapsulated lesion, well demarcated from the surrounding normal thyroid gland. There could be again obviously hemorrhages, areas of hemorrhages or fibrosis or whatever. So these are usually as discrete solitary masses. Okay, so this is the basic findings in cases of a benign lesion, benign tumor of thyroid gland, the follicular adenoma. So moving on to next slide, squamous cell carcinomas. So grossly we had seen how this is originating at the heel of the leg. So here what you see basically, there is nests, sheets, lobules of malignant or the neoplastic squamous cells. This can form sheets or nests of malignant tumor cells. So there could be squamous cell lobules with ertypia, polygonal cells. Cells could be with keratinization or it could be non-keratinizing cells also. So individual cell keratinization also can be seen in a case of squamous cell carcinomas. So as you all know, this is due to ultraviolet rays exposure. Fair skinned people also can succumb to this particular lesion. So squamous cell carcinoma can occur anywhere on your body, or the commonest sites, as you all are aware of, is the oral cavities. So, or it could be even sun exposed areas, old burn scars, betel nut chewing, tobacco chewing, all this. So again microscopically it can be divided into again well differentiated squamous cell carcinoma, moderately differentiated, poorly differentiated squamous cell carcinomas. So depending upon the type of differentiation of squamous cells, especially in case of well differentiated squamous cell carcinoma, what you see, sheets and nests of neoplastic squamous cells with ertypia, hyperchromasia, increase in NC ratio, with keratin pearls, important finding in case of well differentiated squamous cell carcinoma. And another important differential diagnosis of a well differentiated squamous cell carcinoma is a keratoacanthoma, that you should be very much aware of. Yes, what is the important differential diagnosis of well differentiated squamous cell carcinoma? keratoacanthoma. So basically, microscopically, it's well differentiated, moderate differentiated, and poorly differentiated squamous cell carcinoma. What happens in poorly differentiated? The morphology of squamous cells is lost. You're not sure whether a cell of origin is squamous cells or anything else. So completely distorted, bizarre, hyperchromatic cells that you can see in case of poorly differentiated squamous cell carcinoma. So these are the things that you should be aware of. And one more thing, whenever you mention in your diagnosis squamous cell carcinoma, you should be aware whether it is keratinizing squamous cell carcinoma or non-keratinizing squamous cell carcinoma, depending upon whether there is individual cell keratinization or absence of that particular thing. So this is a microscopic that you have to draw proper diagrams. It could be, there could be some inflammatory infiltrates too in these particular lesions. So there are nests of this particular thing, and sometimes this squamous cell carcinoma, which is originating from the epidermis, can invade into the dermis and form the nests inside this particular dermis. So this was a slide, microscopic slide of squamous cell carcinoma. Now moving on to the next slide, basal cell carcinoma. Okay, so also called as rodent ulcer. The other name, the other earlier name was rodent ulcer for this. Again, where you see this? In sun exposed areas of the body, or in people with immunosuppressive drugs who are taking, or where there is low immunity due to various other illness, ailments, diseases, cancers, whatever. So they appear like a pearly papules, pearls on your body. Pearly papules, these lesions. So basically what you see here, this is a slow growing tumor. The metastasis is very, very rare. So the tumor cell nests are of basaloid cells. Scant cytoplasm with hyperchromatic nucleus is a feature of these cells. And classic thing is peripheral palisading. The peripheral basaloid cells are arranged parallelly, like a fence around your homes, parallel fences. So that is palisading arrangement of these particular cells. And due to this particular palisading arrangement, there is separation artifact surrounding these particular nests. So there is a retraction artifact around these nests of basaloid cells. Why is that retraction artifact important in a basal cell carcinoma? Because that helps you to differentiate basal cell carcinoma from other adnexial tumors of the skin, especially like trichoepitheliomas. The differential diagnosis, it is helpful. So one important feature, peripheral palisading of the tumor cells, number one. Number two, the retraction, the peripheral retraction, the separation artifacts of these nests of cells. That is another important finding. So in between there could be surrounded by lymphocytes, the fibroblast in the stroma. So these are basically the basophilic cells with hyperchromatic nuclei. There could be some hyperchromasia in these particular cells. They almost look like uniform cells with peripheral palisading. So there could be mitotic figures or apoptotic bodies also. Okay, so this was about the basal cell carcinomas. So this is the microscopic slide. Now moving on to the last slide of the session, the microscopic slide, that is malignant melanomas, as we already dealt this in gross specimens today. So this is nothing but a malignant lesion of melanoma. So as you all know, again, microscopically melanomas can be classified into vertical growth phase melanomas, horizontal growth phase melanomas, again different types of these particular melanomas you can come across. So all this you should be aware of. Basically what you have to look for in a case of melanoma. So this arises from the melanocytes. Where are these melanocytes? They are scattered at the basal cell layer. So where you see in these fair, as I told, fair skin people, it could common site could be upper back, legs, or even a pre-existing mole. Suddenly you have a mole on your body and suddenly you develop itching on that particular mole or the nevus, that's a benign lesion of melanocytes. Sudden itching in a pre-existing mole is a dangerous sign. An irregularity of that particular nevus, if there is increased irregularity day by day, an increased size, and increased a change in color of that lesion of the nevus, normal nevus, could be a dangerous sign. It could be slowly progressing towards a melanoma that you should all be aware of. Okay, so this is again depending upon the vertical growth phase, horizontal growth phase. Again, there are four types: nodular sclerosis, acral lentiginous, superficial spreading, lentigo maligna melanoma. So all these four types. So an important one is the nodular sclerosis, that is the vertical growth phase. Again, horizontal growth phase again could be in the form of superficial spreading and all that. Okay, so what basically you have to look for here? The cell nests of malignant melanoma cells. So where you have to look for these? This could be there could be increased junctional activity of these particular melanocytes. So there is increased junctional activity. So there could be intracytoplasmic melanin or extracellular melanin. So melanin can be seen both, the brownish pigment, intracellular and extracellular. The important area where you have to focus is junction, that is dermoepidermal junction. There is increased activity, whereas in cases of nevus you won't get such activity. Okay, so this is nodular sclerosis type, superficial spreading, lentigo maligna, acral lentiginous types. So these particular neoplastic malignant cells have got brownish pigment in their cytoplasm, increased NC ratio. Sometimes bizarre cells can also be seen in this particular thing. So what are the commonest sites? As we all know, oral, it could be seen on the skin, oral cavity, anogenital mucosal surface, even in the esophagus, in the meninges, in the eyes, wherever, and even in the areas where it is exposed to the sun. So these are the malignant melanoma. So what you have to, the diagram you have to focus here is this particular junctional activity. Okay, so then individual cell melanin pigment, intracytoplasmic melanin pigment, and then the prominent eosinophilic nucleoli, the macronucleoli. All these features has to be focused in a case of malignant melanoma. So basically what all we studied in today's class, as you all know, so revising that, 3 gross specimens followed by 5 microscopic slides. Gross specimens, we described about the squamous cell carcinoma of the foot, the heel growth, how this cauliflower like growth exudes out from the surface of the skin. Then malignant melanoma, again of the foot, again was the originating site was from the heel. The only difference, basic difference, was the blackened gross mass. Around 4 centimeter mass, that particular mass was blackened out. So that is important differentiating point from a squamous cell carcinoma. So usually squamous cell carcinoma presents as a cauliflower like growth without any pigment, whereas malignant melanoma presents with a growth with a blackened area most of the times whenever there is melanocytic melanoma, except in cases of amelanotic melanoma, which is again another variant of this particular melanomas. And then we saw about the gross specimen of the adenocarcinoma cecum, how there was a big nodule, the growth, the mass inside the lumen of the cecum. And the important differential diagnosis that you should be aware of when dealing with adenocarcinoma cecum was tubercular intestine, wherein you see extensive fibrotic scar that differentiates tubercular ileocecal tuberculosis from adenocarcinoma of the cecum, or when you tuberculosis of the cecum, whatever. So the basic differences, the important differentiating point that you should be aware of, that you have to differentiate, is adenocarcinoma from a tuberculosis of that particular site. The other microscopic slides that we saw about the squamous papillomas, follicular adenoma of the thyroid, squamous cell carcinomas, basal cell carcinomas, and the melanoma. Thank you all of you. And this brings to the end of the practical session today. Here Dr. Rajesh signing off. Thank you.